have some alarms as well that would fall into these categories. And remember, the big difference between the invasive mechanical ventilation and the non-invasive, of course, is the presence of that endotracheal or tracheostomy tube. It's very important, of course, that we evaluate to make sure that our patient can protect his or her own airway. So moving on a little bit to a different perspective, now we need to talk about the type of orientation of the machine. Is this a pressure-oriented machine or a volume-oriented machine? And it's important to do that because our alarms are going to be affected in different ways. So if my patient is in a pressure mode of some sort, then the breath will terminate when a preset pressure is reached. So the dependent variable is your volume, your tidal volume, and that's going to depend on the amount of pressure you have set, the amount of patient compliance and resistance depending on whatever disease process the patient might have. On the flip side, we have volume ventilation, which is where our breath is terminated when a preset volume, tidal volume, is reached. Your dependent variable at this point is pressure, and of course, dependent on the same variables, patient compliance and resistance, as well as the tidal volume you have set. Now, we've listed a few modes over to the side, but the focus really isn't in talking about the modes per se, but rather what alarm might be breached, what have we done to cause it, and how are we going to correct that alarm to ensure patient safety. So moving on to talk about breath types. On the left side of the screen, we have listed 3 different categories, although I will say that some authors would argue that the supported category really belongs under spontaneous because both of these are patient-initiated breaths. And then we have a mandatory type, which is the machine-initiated breath.